Welcome back, Focus learners, to this explainer. If you're a medical coder, a CDI specialist, or an inpatient reimbursement auditor, you're going to want to treat this like your essential survival guide. Today, we're cracking open Chapter 10 of the ICD-10-CM guidelines to master some of the absolute most critical and, honestly, most frequently misunderstood respiratory coding rules out there. Specifically, we're going to decode the complex regulations surrounding influenza and ventilator-associated pneumonia, or VAP. All right, let's just dive right in. Here is our roadmap for today. 1. Influenza exceptions. 2. Suspected cases default rules. 3. The VAP documentation mandate. 4. Post-admission VAP sequencing. And 5. A knowledge corner focusing on principal diagnosis.
Starting with Section 1, Influenza exceptions and breaking the inpatient rules.
You know, the respiratory system guidelines have some pretty fascinating quirks. Just take a look at how these two major coding concepts clash. Over on the right, you've got your standard hospital inpatient guidelines Section 2H, the uncertain diagnosis rule. We all know this one, right? Usually in an inpatient setting, if a condition is documented as suspected or probable at the time of discharge, you code it as if it exists. But look over on the left. Influenza due to certain identified viruses, like categories J9 and J10, acts as a strict exception to this rule. You are only allowed to code confirmed cases of influenza due to certain identified viruses, like avian, novel influenza A, H1N1, or H3N2. If you don't have confirmation, well, you simply cannot use J9 or J10, period. But wait, what exactly does confirmation even mean in this context? I am issuing a major audit alert right here. This perfectly illustrates a very common misstep. Confirmation does not require documentation of a positive laboratory test specific to that strain. Let me repeat that because it's crucial. Positive lab testing is absolutely not mandatory. Your coding should be based purely on the provider's diagnostic statement. If the provider explicitly documents that the patient has avian influenza or H1N1, you take them at their word. You assign the specific category J09 or J10 code, regardless of whether a positive lab report is actually sitting in the chart.
Moving on to Section 2, Suspected Cases Default Rules, or what I like to call the J11 route.
So what happens when the provider isn't entirely sure? Well, if a provider's documentation includes any of these trigger words, suspected, possible, or probable, when referring to avian, novel, or other identified influenza, you must immediately hit the brakes. You cannot assign a code from category J09 or J10. Instead, the guidelines strictly mandate that you default straight to category J11, influenza due to unidentified influenza virus. So the takeaway here is to always be scanning for that definitive diagnostic statement. The exact moment you see hesitation words, like probable, J11 is your only compliant path forward. Section 3, VAP, the documentation mandate, and avoiding the miscoding trap.
All right, we are pivoting to post-procedural respiratory complications now. Let me be clear. Miscoding ventilator-associated pneumonia is a massive compliance risk. Getting this right is completely non-negotiable for auditors. This brings us to perhaps the most vital concept in this entire explainer, provider linkage. Imagine a patient intubated after trauma who suddenly develops a fever. Listen carefully. Just because they are on a mechanical vent and have pneumonia does not automatically equal VAP. The provider must establish that clinical relationship in the chart. Code J95.851 for ventilator-associated pneumonia can only be assigned when the provider has explicitly documented VAP. If a patient is on a vent, has pneumonia, but the documentation doesn't specifically state the pneumonia is ventilator-associated, you cannot assign J95.851. If the documentation is murky, this is a prime textbook scenario where you must query the provider for clarification. Do not guess.
Taking a quick look at the category J95.85 hierarchy maps exactly where our VAP code actually lives. You've got J95.850 for mechanical complications, J95.851 specifically for ventilator-associated pneumonia, and J95.859 for other complications of a respirator. Mentally anchoring exactly where this code sits within the broader category of respirator complications is going to help ensure you're selecting the precise code for the clinical picture documented in your chart. Now for another massive audit alert, this time regarding VAP combination coding rules. When you do have a confirmed VAP diagnosis and you assign J95.851, you're not done. You must also assign an additional secondary code to identify the organism, for example, code B96.5 for Pseudomonas aeruginosa. However, look at that second bullet very carefully.
You must never assign an additional code from categories J12 through J18 to identify the type of pneumonia. The guidelines strictly prohibit using those standard pneumonia codes when the condition is VAP. It's a hard never.
Section 4. Post-admission VAP sequencing. Chronology is key.
So, what happens when the patient doesn't come in with VAP but they develop it during their stay? Let's walk through how this builds using a simple step-by-step sequencing flow. Imagine a patient is admitted with a community-acquired bacterial pneumonia. At the time of admission, the provider diagnoses pneumonia due to Streptococcus pneumoniae. Step 1. You'll assign the appropriate code from categories J12 through J18 as the principal diagnosis, so in this case, J13. But let's say a few days later things take a turn, the patient is intubated, and they subsequently develop VAP. Step 2. Code J95.851 for ventilator-associated pneumonia is assigned as an additional secondary diagnosis, provided, of course, the physician explicitly documented that linkage. The admission diagnosis keeps that principal spot. Section 5. Knowledge Corner. Principal diagnosis.
All right, here is a really complex chart abstraction scenario for you. A patient presents with 3 severe acute respiratory conditions all at once: acute pneumococcal pneumonia, acute respiratory failure, and an exacerbation of moderate persistent asthma with status asthmaticus. So take a look at these 3 codes: J13, J96.00, and J45.42. As a savvy auditor or coder, how do you determine which of these competing acute conditions gets that coveted principal diagnosis slot? Think about it for a second.
Okay, and here's the resolution. The official guidelines state that when a patient is seen for respiratory failure and another acute condition, like our bacterial pneumonia here, the principal diagnosis actually isn't the same in every single situation. The absolute rule of thumb is that the principal diagnosis depends entirely on the problem chiefly responsible for the encounter. You have to query the provider or meticulously review the admission H&P to determine the primary catalyst for the admission. Was the patient admitted primarily to manage the severe asthma attack, to treat the advancing pneumonia, or to mechanically support the respiratory failure? The clinical circumstances of admission completely dictate the sequence.
Summary and next steps, wrapping up Chapter 10.
To wrap this all up, here are your core compliance rules from today's explainer. First, always default to Category J11 if a specific influenza strain is only documented as suspected, possible, or probable. Second, never assign VAP code J95.851 without explicit provider documentation linking that mechanical ventilator to the pneumonia. And finally, when coding VAP, ensure you capture the causal organism, but absolutely never use codes from categories J12 through J18 to define the VAP type. You now have the auditor's playbook for navigating these incredibly tricky Chapter 10 scenarios. But I want to leave you with a thought. How many records in your own facility are currently sitting there with unlinked VAP diagnoses, silently waiting for an auditor's query? It's something to think about. Next time, in Part 10, we are going to dive into the emerging guidelines for vaping-related disorders, take a sneak peek at the ICD 2026 updates, and deliver our final respiratory course wrap-up. You definitely won't want to miss it. Until then, stay focused, stay compliant, and decode healthcare with Harshal.